Yeah, Marty,
Okay.
you might want to use your phone for your audio.
Hey, Larry, Jerome Lothridge, can you hear me?
I can hear you.
Great, thank you.
I see you on there, your administration.
That's me.
I don't see your face, but I hear your voice.
Got a face made for radio.
Thank you for being on.
You bet. Thank you all.
Gentlemen, we are live.
All right. I want to welcome everybody to the COVID pandemic, what you need to know from the Oklahoma State Medical Association. Just so everybody knows, we have more than 400 participants listening. And if you have questions, you can go on the YouTube chat and send your questions in. They will be texted to me, and I will try to get all questions answered during this live study that we're doing. Currently, we are on the website at okmed.org, so that if anybody needs to find the site, okmed.org on the OSMA website. And I want to start off by, first of all, thanking all of our participants. And we have Anthony Lee, Director of Acute Disease Services, Secretary of Health and Mental Health, Jerome Lothridge, Dale Bratzler, Professor and Chair of the Department of Health Administration, Marty Hendrick, PharmD, who's Executive Director of the Pharmacy Board, and Thomas Kupiak, who's the CEO, ARL Biopharma and DNA Solutions. So we have quite a knowledgeable and expert panel to try to answer questions that come in. At present, we now have 988 confirmed cases in Oklahoma and 38 deaths. Information is the main source that we can help our patients with without direct treatment, emphasizing staying at home, washing our hands, cleaning our hard surfaces, but most of all, stay at home. Keep our social distancing. That's something that all of us can be telling our family, our friends, as well as our patients. I'm going to start off with Mr. Lee. The first question is, what is COVID-19, also known as novel coronavirus, and why is it spreading so rapidly?
Great, thank you. Good afternoon, everyone. Yes, so COVID-19 is a novel coronavirus, and so it's very similar to SARS and MERS, and it causes symptoms such as fever, cough, shortness of breath, and things. And really, the main reason why it is spreading so rapidly is because it is new, and so the people that are exposed to it, have not had a chance to develop any sort of antibodies to it, and to build up that defense. And so it's going through pretty rapidly through our population.
It's highly infectious, and as we said at the beginning, it can even be on the hard surfaces. We've shown cardboard and plastic. It may be there for several days. So the ease at which it spreads and its infectivity is really what's creating a lot of our problems. Secretary Lothridge, are the hospitals and other health facilities prepared to treat what may be a large influx or what's called the surge?
Thanks, Dr. Berkman. I really couldn't say enough about how the hospitals have participated in the collaborative planning for the surge. All of us, even the general public who have not extensively involved themselves in things like statistical modeling over their lives, have in the last couple of weeks become intimately familiar with things like the shapes.
I think you went off air real quickly, Secretary Lothridge. There you go.
How they have collaboratively participated in this process. Can you hear me, Larry?
Yes.
Okay. The short answer is yes, and we are preparing on a daily basis with both the Hospital Association and individual medical centers such that when the surge comes, and again, by various models, we do estimate that that's mid toward end of April. But I believe that we will be in good stead relative to those critical choke points of ICU beds and ventilatory capacity. So not easy, and we don't have much berth there, but I believe that the collaboration that the hospitals are providing in our planning process will accommodate what we see at this point. If that's not the case, I would let folks know that we have engaged National Guard and Corps of Engineers on flex up planning. That is aggressively underway, such that if we do have to pull in additional capacity outside the hard walls of our hospitals and medical facilities, I believe we'll be in a good position to do that.
Dr. Bratzler, questions have come in on what specific things a physician should do to prepare his or her office and staff for the virus, and what should primary care especially be telling their patients who are concerned about COVID-19 and its spread?
Yeah, so that's a big question. So certainly early when we knew we were going to see substantial increase in the number of cases, we moved most of our elective visits or the walking well patients, the patients that are just coming in for routine checks. We canceled most of those or rescheduled them for much later. I think many practices across the state have broadly implemented telemedicine as an approach to taking care of patients, to reduce the number of face-to-face visits. Still, some patients need to come in. So when we have patients arrive in our clinics, we are screening them all. Right now, we're doing temperature testing and questions, but that's not enough. We know now that asymptomatic patients can spread this particular virus. So I'm very skeptical about our efforts to just do testing with temperature taking and screening. So we are very aggressively working towards putting masks on any patient that comes into our clinics. We do that now in our cancer center because we know that patients who come in who have absolutely no symptoms, that may be coming in to get their diabetes checked or some other condition, could be transmitting the infection. And by putting a mask on the patient, we can potentially protect the staff and other patients around them.
And certainly if any of the other participants want to jump in, please feel free to do so. Are there enough COVID-19 test kits? This may be both for Secretary Lothridge and for Dr. Kupiak. Dr. Kupiak, you want to talk about the testing, what is going on, and then Secretary Lothridge can talk about the numbers.
Yes, sir. There are basically two types of tests. There's more than two types, but in general, the standard is the real-time PCR or the nasal pharyngeal test, and that's actually testing for the shedding virus and active. There are tests that are being conducted where ARL is participating and working with Stanford and University of Southern Cal and a couple other entities on looking at this rapid on-site test that measures the IgM and IgG. The difficulty is the tests have not been available. We don't really know the true prevalence due to the lack of the test and the test are the numbers real? And so just yesterday, the FDA approved its first COVID-19 IgG and IgM test that is available. And that test is important because it detects the SARS-CoV-2 antibodies, IgM, which are more recently developed. And then later, as the disease progresses, you can develop the IgG. Then the rapid or the real-time PCR is more the gold standard, or perhaps the standard that's more accurate and being used in our society today for the actual testing. The availability of the tests, Mr. Lothridge would be the best to communicate that.
So Jerome, do you want to pick up on, I know we have relaxed a lot of the rules that were originally in place, and we're trying to test more and more with more sites. You want to jump in and talk about testing in Oklahoma?
Sure, Dr. Bittman, and thank you, Dr. Kupiak. That was a a great rundown of sort of the variant available testing capabilities. I would say that on the standard sort of PCR that everyone has used, that's clearly the one most persistent available to us. And so a couple of meaningful movements over the last week. We were subject to, I think, the same really international market forces as were the rest of the states, really from 2 weeks ago till about 7 days ago, whereupon we were extremely limited in our testing capacity within our state. And in fact, we're manifestly rationing the availability of testing. There really wasn't any other choice. I think that has relaxed by virtue of great work, especially with our university partners. I highlight both Oklahoma State University and emerging work at University of Oklahoma. As it sits right now, as to orient folks around the availability, we have about 13,000 test kits available. And by test kits, I stipulate that that does include reagent, which we know to have gone short in supply over the last few weeks. So 13,000 test kits available, most particularly housed up at Oklahoma State University at present. There are also some 500 to 700 available at the Oklahoma State Department of Health. And I might just advise, particularly germane to the audience here, we have specifically stipulated that those tests conducted at the Oklahoma State Department of Health are being reserved for 3 particular groups. The hospital workers, or more generally, healthcare workers, the hospitalized, and those individuals working in long-term care facilities. And so for folks that are on this call and for people who work alongside you as frontline healthcare workers, we've reserved now our state health department's testing capacity for you. Now, more generally, the available tests that are currently resident up at Oklahoma State University are what we're trying to leverage to cut down our wait time. So imperfect though these PCR tests are, as Dr. Kupiak advised, they do beat, they beat nothing on the one hand, and we absolutely must increase testing to have a better understanding of where we sit along, along the curve, where we sit with respect to true prevalence in the population. These are all things with which you're very familiar, but it is a trick to pivot, as we've had to, from a position of scarcity now to a position where we are encouraging the public to test. Again, not the walking well who might just be curious, but anyone exhibiting symptoms. We have relaxed that now in an effort to broaden our testing base and therefore broaden the number of folks that we have information on.
A question has come in that Secretary Loffridge would be for you. It says, this is from Paul Darden. I'm hearing from primary care that they don't have PPE and are reluctant to see potential COVID-19 patients. Is there any help for the private practices?
Sure. Thank you for that. PPE, another one of those terms very familiar to this audience, but now certainly in the common parlance as well. PPE has been, if not our primary focus over the last 14 days, it has to be among the very top. And the supply chains continue apace from our large medical systems, of course. But we do have available PPE, specifically through our strategic national stockpile. That too had run well behind, and until about 5 days ago, we had only received about a quarter to a third of our state allotment from the federal strategic national stockpile. We do now have 100% of that in receipt. So for medical providers who have gone short or are in danger of going short capacity on that, we do have supplies that can be resourced for that. I would tell you that some portion of that supply certainly involves, most particularly with respect to N95 masks. Many of those are past their date, and we're probably mostly aware that an N95 mask carries a 5-year expiration from its time of manufacture. And so much of what we received into the strategic national stockpile, probably understandably, was coming out of national stocks that were somewhat aged. And so they might be 6, 7 years old. We know the most vulnerable part of that is not actually the the ventilation itself, but in fact, the rubber band that keeps it affixed, to the face. So I stipulate that only to let folks know that we do have those available, and in emergent situations, we can push those out. And if that's the need, please contact the State Department of Health, and we can get that moving.
All right, a question I'll just throw open to anybody on the panel. Do we have any idea what percentage age of people who have COVID-19 are totally asymptomatic? That has a lot of impact on what the final mortality statistics will be. So do we know what percentage in the different age brackets are not symptomatic?
So this is Dale. We clearly know that young children and teenagers are much less likely to have symptoms than older people are. That's been demonstrated in a number of studies. Not only do they have fewer complications and fewer bad outcomes, but they're less likely to actually demonstrate symptoms. So it's been a big concern for our pediatric practices, and it's one of the reasons that at the Children's Hospital, we put into place very extensive screening of anybody that walks into the building and putting masks on everybody that are coming in, because those kids, though they may have no symptoms at all, could be vectors of the virus.
And we absolutely know that our younger people can be vectors. And what's most important, especially in our young people, 18, 20-year-olds, that they can carry at home. And in fact, their elders who may have underlying disease, may have comorbid conditions. And so it's important that they understand that they can be carriers, and that they need to be just as cautious as those of us who are over 65. So one of the important questions here, and I'll give this to Dr. Kupiec, is why is the CDC not recognizing the e-swab with the Ames auger testing, even though it's FDA approved? Is it not reliable?
I can't comment on that. I don't have the data. Typically a test, any test that you want to run, it should have appropriate validation and verification parameters, which would include sensitivity and selectivity, and you would plot that using an ROC curve. So there's appropriate protocol that the FDA would do for medical devices to evaluate that. So I had not reviewed that data, so I cannot attest to or communicate regarding that particular testing in regards to the CDC.
Anybody else want to comment on that particular question? This is for Dr. Hendrick then. We've talked a lot in the press, and we talked a little bit here about the hydroxychloroquine, azithromycin, and also using convalescent serum. The question is, what effect do these treatments have? Are they effective? And should they be utilized?
We'd start out with the serum. I think that's probably the least proven of anything. And as far as the data goes with it, there's not a lot of data out there right now. I think it's limited of what we know. We're seeing a lot of trial and error out there. Obviously, Plaquenil and the azithromycin for that secondary infection of the lungs is what we see being used the most. A few weeks ago, Governor Stitt put into an executive order that limited the use of Plaquenil and how it could be used. So the day supply, that way we wouldn't run out here in the state of Oklahoma. Right now, we do have low amounts of those drugs that are out there. I'm not going to say that there's a ton just sitting on hand, but there's backup plans with those medications as we move forward and we find out more of their effectiveness. I think those two seem to be the one that most people are clinging on to, or that have the most data that goes along with it. Is the data just blow you out of the water? Great data? No, I wouldn't say so. But we're into something that's very early, and something that we haven't had a lot of time to study, to research, and to put all the information into. And I mean, you would find that in any situation, that sometimes you use things that work in a number that's very small in the hopes that it's going to be a number that will grow and grow and grow and that it works for everyone. But that's not always the case. So I would say as far as the serum wise, that's probably the least studied, the least known entity that we have right now. I think Plaquenil and azithromycin have made their place as a mainstay, but I've read, studies that contradict that say it had no effect whatsoever. So it's kind of a pull your hair out type game here of whether, we have something that we can hold on to and work with, but we also don't want to create panic and then create a shortage with the drug too. And that's what we see in pharmacy. I have a lot of pharmacists across the state that are on a limited supply, and they have patients that use Plaquenil for other reasons, such as systemic lupus, rheumatoid arthritis, those things that go into it. They don't want to just go ahead and evaporate that supply for those patients that need that medication monthly too. So we're kind of on a delicate balancing game here where we want to be accommodating to everyone as much as possible, but we also don't want to leave those patients that need this medication monthly, in the dark or without and searching for that medication. So does anything really have, the gold star next to it? No, not at this time. It's unfortunate, but this is what happens when we're into something so new and something we don't really know a lot about yet.
Yeah, Larry?
Yes.
This is Dale. I want to also comment on that. I really appreciate those comments. I've had a number of patients actually call me that were virtually asymptomatic or had very mild symptoms. They wanted me to call the pharmacist and tell the pharmacist that their test was positive so they could get the Plaquenil and Z-Pak that their physician prescribed for them. And so far I've been successful in talking all of them out of taking it because honestly, their symptoms were simply did not warrant being treated with those medications. I think it's very, very important that the clinicians in this state understand that the evidence that this works is razor thin. There are no really good controlled studies. The only study that came out of France that a lot of people hung their hat on only had 36 patients in it, only 16 of which were in the control group, and many of the patients didn't respond. The sickest patients didn't respond. I talked to one of our pulmonologists earlier today, and he has no hope at this point that hydroxychloroquine and azithromycin are impacting our patients, particularly the sick ones on the ventilator. So we're trying it in the context of clinical trials, and I think that's quite appropriate. But there is virtually no evidence yet that it actually improves. There is no evidence that it improves patient outcomes. There's a little suggestion that it may reduce viral load, but not patient outcomes. So I think people have to be cautious. There are side effects from these medications also.
Yeah, I think it's also important to recognize the executive order that the governor put out that limited the number of days if a prescription is written, and then a diagnosis must be on the prescription, and that the pharmacist needs to be looking at that and has the right, if there's no diagnosis, to reject the prescription. So those are important. And the questions that were asked is, who do you treat with Plaquenil? I think we've answered that only the only severely ill hospitalized patients are even being attempted. And can we use Plaquenil for prevention? And I think the summary of that answer would be no, that it's not used for prevention. A question that was sent in, can you mention again the sensitivity, specificity of the PCR test? Dr. Kupiec, concerned about false negative rate in setting patients with concerned symptoms who test negative and want to go back to work. You want to comment on that?
Well, what we mean by a false positive and false negative is, a false positive is if an individual actually is positive and it's related as negative, that would be a false, it'd be a false positive. A false negative is the inverse. If you get a negative result of the PCR test, the person is really positive. And it could be due, that PCR base or the false test result could be due to a sample collection site. I mean, we know that that's just as important. So It's almost site and collection time at the disease progression. So there are many variables that indicate a response to a test. And this sensitivity and selectivity are important. Selectivity, we're referring to the accuracy of what is it responding to? Is it responding to that COVID-19 virus or response? Or is it, as in the concern that we had for the rapid test was the lack of sensitivity. I think the sensitivity or selectivity for the rapid point of care test are probably true because they're probably based upon the epitope from China. However, I think right now that PCR, real-time PCR test is probably the best we have. I know there's a lot of stuff being developed. There's a lot of things working on it, but that is one of the things that creates consternation. Is this coronavirus is new. This particular strain is new, and so it hasn't had time to develop the medications or the treatment or the therapy or the vaccines present. And so a lot of the information, typically medicine, you want strong evidence and scientific based. A drug that would go through the FDA process, I back up strongly what Dr. Bratzler and Dr. Marty had indicated, that there are a lot of questions are being used for this, and that is a problem. I mean, you'd like to have meta-analysis. Now, being real, being over 60, if I was on my deathbed, I would be making an emotional decision, give me hydroxyquinone, these other alternatives, but is it really going to be effective? We don't know yet. So I think we need to try to discern what is reality, what is fact, and what is fiction. And it should be as close as possible, be scientifically and evidence-based.
Yeah, and I think the emphasis to the clinicians on this conference is to stick to the science, try to avoid all the anecdotal stories that may be in the press. Secretary Lothridge, one of the questions that's asked is, how have we relaxed the rules? We keep saying we've relaxed them. How has that been done? And we want to follow up with that because that's about testing. Dr. Bratzler, the next question is how do we confirm recovery? So Secretary Lothridge, you want to talk about how the rules have been relaxed?
Sure, thank you. So to walk back in this last year that we've lived since 2 weeks ago, certainly we were in this 2 week ago period in a position to have to ration testing. We've already kind of recounted how that happened really worldwide. We are not now in that position again to repeat with PCR tests. We do have available an amount that will provide a reasonable cadence for testing. But I'm confident that pivot probably has not yet occurred. Here is what I would say, and let me give a couple of examples of where this may be unclear. As of a week ago, we really said that we needed folks to be, through our screening, it would have included both the presentation of symptoms and either in an elderly cohort and or immunocompromised or having had exposure. So these were the criterion that we had to hold high when we had a limited supply. We do not now have that same supply constraint. And so while on the one hand, we certainly don't want people just testing out of curiosity or testing in the absence of a presentation of symptoms, for those people who are symptomatic, we are actively encouraging them to seek out testing. Now, if I could just walk a bit of the mechanics again, all of our health systems have, there's a true panoply of sources for testing. And at this point still, if folks are contracted with private labs, likely as not, those samples are going to have to go elsewhere out of state to be completed. That was even the case as early as last week with the State Department of Health, where our contract with DLO saw those samples have to go to Dallas to be completed, thereby creating at least a couple, if not several day round trip. In some of the other private labs, we know some samples have gone as far away as California. That created a 5, 6, 7 day lag on return. Now that we have testing capacity inside the state borders, Our aspiration, and we think our our realistic potential, is to have 24-hour turnaround. But what that means is this relaxation of standards to achieve that population level testing, we really have to push through our provider community. And so, Dr. Bookman, that's why I'm appreciative of this particular time. We need help getting that message out. We know that it does represent a pivot. It is derived from our stock that we now have that we did not have as recently as a week ago. And the other thing that we know to have been a little confusing is that some of our larger drive-up facilities, most notably Oklahoma City County Health and Tulsa City County Health, had been operating under different strictures. And so we know, for instance, that they required a prescription and at least in a couple of cases required even a schedule ahead for testing. By virtue of the governor's action yesterday under the CHE, catastrophic health emergency, now those two city county health departments roll up under the State Department of Health. We're going to extend the same standards for testing across those as we maintain now at the State Department of Health. And so again, the message is we want folks to test broadly where there's a presentation of symptoms, and then we want to return those tests rapidly by virtue of conducting them inside the state borders instead of sending them out.
And this is Dale. I'll just comment on the how do you get, how do you decide when a person can return to the community, go back to work? I think those of us, Dr. Drevitz and several of us on campus talk about this all the time. We would prefer to retest and have a negative follow-up test, but that hasn't been possible in the past, although we have put some of those protocols into place for healthcare workers that we deem essential so we can get them back into the workforce as quickly as possible. The current CDC recommendations are, in the absence of a retest, is that the patient has to be at least 3 days afebrile on no antipyretic medications and at least 7 days from the onset of their original symptoms. Once you meet those two criteria, the 7-3 rule, then you can return to work, though most of those patients, obviously, those patients are not being tested.
And I will add that Dr. Fauci has commented, if you read his works, that in the ideal world with adequate tests, he recommends before somebody's considered negative, that they have 2 negative tests separated by 24 hours. Again, that's, in the ideal world where there's enough tests to do that. And let me also say that for those who need to know, there is a call number for the state lab, 211 can be called for the state health department lab. So that number is important to keep on hand for any patients who may have questions or for physicians who may have questions. We have a question here as far, and Anthony, this may be for you, as far as reporting, are deaths being reported based on the patient's home, where they were tested, or where they died? Same for positive tests.
Okay, yes, and so it would be for the residents, so the county of residents in terms of how it's being reported. Yeah, and so, so just to go along a little further than that, in terms of, the laboratory, the clinician, they're both supposed to report to the state health department. And so then actually when we receive a positive test, we assign that out to the county department nurse for investigation. And then they do follow up, and they follow up to look at the contacts that they may have had and then examine close contacts. So actually, if there was somebody that was in a healthcare facility or a long-term care facility, we would examine those possible exposures there and would conduct the contact investigations along those lines. Okay.
A question that has been asked, this may be for Dr. Kupiec. It says, what about Abbott's molecular testing? Is specificity better? Abbott obviously released their testing and supposedly sending out 50,000 per day. And after you answer, Jerome, you may want to talk about what the state found out about some of the scams that are out there.
I believe the Abbott test has a good and fair specificity. Yes, I think any test that's gone through the FDA or even been evaluated, there's a fairly high standard. And that's my concern, maybe of some of the overstating specificity or sensitivities from some of the tests that are coming outside the United States. But I think that it is a fair specificity, yes.
Jerome, you want to talk about some of the things the state found out?
Yes, Dr. Brittman. Fortunately, we will have a very limited supply coming directly from Abbott that will come in through the Office of Emergency Management. It will not be a large supply. It's really almost a starter kit, and those are going to be limited use. Regrettably, in this situation, much like, frankly, the false manufacture of NIOSH qualified N95 masks, we have unfortunately seen the emergence of fraudulent rapid tests. And as Dr. Kupiak mentioned, it's critically important to get these right. And some that have been found now available in the market are pure shams. And we had moved aggressively at the state to try to source these rapid tests. Frankly, we put that on hold for fear of getting something that would be at least ineffective and potentially harmful to patients. That's one of these regrettable, outcomes in an epidemic situation. We do look forward to Abbott and its provision of these tests. We are, of course, a small state. We're fighting for our share or more, but availability of that test within our state borders is somewhat yet to come. We do anticipate, though, as of today, having a very, very limited number that we will at least be able to start to get our hands around.
Jerome, this is also maybe for you. Are any of the testing sites in Oklahoma using the patient self-administered nasal swab test that the FDA approved last week?
Great question. Not yet, Dr. Bookman. We're still using the sort of standard issue swab. And so I'm not sure. I'm happy to get back with the group when we do pursue something like the self-administered. But to date, it does require that a professional be on site to help that happen.
All right. This is a question that's been asked multiple times for Dr. Hendrick. What effect do NSAIDs such as ibuprofen have on patients with COVID-19? Obviously, the World Health Organization originally came out with a warning and then reversed themselves. You want to discuss NSAID use?
I mean, we've seen evidence, and I'm not even going to use the word evidence because once again, the numbers of people that are using these, as far as test results, I mean, it's hard to equate that into a study. But we're seeing two different relations of the NSAIDs of whether they're being effective or not in the scenario that we're talking about. I'm personally undecided on this because I don't think there's any evidence either way that's going to guide us to what we should do and what would be proper in these situations. I mean, obviously, when we first started out, we were ruling that NSAIDs were a no-no in this situation, and now we're starting to backstep that a little bit and saying the possibility of what these possibly can do in the situation. I still don't think there's any evidence out there. And I think once again, we all jump to conclusions of, we hear a news story and we go with it and everyone just guides themselves to that as that's the truth verbatim, when in evidence, there might be a lot of different scenarios that goes along with that could guide us to a different answer than what we're looking at. I don't think there's any correct answer with that. My correlation with that, I don't think there's anything strong correlating it to or against and what its effect is with the coronavirus or COVID-19 at this time.
Yeah, Larry, this is one of the most interesting stories about how the news media jumped on something. I did quite a bit of research on this one. There was a single paper that came out of Switzerland that suggested that ibuprofen might worsen symptoms or progression of COVID-19. It was a speculative article. It had no study data in it. They just speculated that it might cause a concern. And then the Minister of Health in France tweeted out that we shouldn't do it, and it was picked up by all the news outlets. And then all of a sudden, all over the country, we saw these news stories that you should definitely not use ibuprofen if you had COVID-19. As Marty said, or as you said, Larry, the World Health Organization reversed themselves. And I always point people to the FDA statement, because the FDA came out with a statement saying that there's no evidence of any ill concerns about using ibuprofen or other NSAIDs in a patient with COVID-19. Again, maybe there will be after study, but at this point, there is no evidence.
Yeah, I think the statement that came out of France was the one that everybody picked up on, and there was no scientific evidence behind that at all. So I'm not going to read this question, but I will comment. It's about why our governor is limiting our ability to get antibiotics like Plaquenil. And we've talked about that. The governor is not limiting the ability of people to get Plaquenil. It has not been proven to work. It is speculative, and there are people who need it, who have medical problems, who have been on it, who need it. And if people run out, as they did under panic situations, and reduce the supply, or in some cases where it's not available, for those who need it for true clinical reasons. So there's no reason to really move on with that. One very interesting question is, how can we educate more people about false negative nasal swabs? The JAMA article of about 63%, which can be partly overcome by repeat testing. Concerned about false reassurance and limited availability of repeat testing. Dr. Kupiak, do you want to comment on that?
I think that as we were talking earlier, that the point at which you're in the disease state will indicate, and also the site, and even the sensitivity and selectivity of the assay or the test. So I think there's several factors that are going to enter into that false reading that an individual. Both the collection are important, as well as the testing process or assay mechanism itself are important. Thus, furthermore, to reiterate the importance of validation and ensure that the product is appropriate quality.
Absolutely. Anthony, a question has been asked by one of the providers, when the next Health Alert Network will be coming out. Do you have any answer to that?
Yes, we're planning on sending one out probably early next week with revised guidance on testing at the Public Health Laboratory.
Okay. For those who don't know, the Health Alert Network, I don't believe goes out to every provider, but you can sign up at the Oklahoma State Department of Health website, and you will get Health Alert Network alerts by email on a frequent, if not irregular basis. So right, certainly yes, worth signing up for if you are not receiving them now. A question from one of our providers is, do you anticipate that antibody testing will be made available to all healthcare workers so they can be screened and know whether or not they've had exposure and may have immunity? I don't know, Jerome, do you want to take it? Dr. Kupiak or Dr. Bratzler? I don't know. Nobody's jumping on that one.
I'll put myself in the position of listener from the policymaking standpoint and defer to Dr. Bratzler and Kupiak as to the efficacy of that.
Yeah, so this is Dale, and of course, as Dr. Kupiak mentioned earlier, there is an FDA-approved test on the market now. So I guess, once it's out there, you can get the test done if you want to. I don't know that we know exactly what the results will mean at this point, but the thing I'm excited about, one of the reasons I'm really excited that we're going to have antibody tests out there on the market is I think it's going to be very, very important in the development of any vaccine trials that we know whether a patient has been previously exposed or not, whether they already have circulating antibodies or whether the antibodies that a patient develops are from the vaccine. So I think it's a really, really important development. I don't know yet how it will play into treatment or decisions about ongoing work and things like that. But I think it's really, really important.
I think this is a very important question. Jerome, this is definitely for you from one of our primary care doctors. Is why are we not going to a uniform statewide stay-at-home policy like many other states have already done? A uniform statewide policy would seem to cause less confusion for the public.
Sure. Thanks, Dr. Bergman. I certainly understand the sentiment, and I can simply relay the governor's intent on that. So the current policy is that as counties, individual counties encounter COVID positive cases, they fall into a different category than those that don't. The conjecture behind that was simply that this is a two-front battle. Clearly, there's a medical battle going on with respect to COVID-19, and there's also there's an economic battle that is that though we that has not obviously been appropriately the topic of our conversation here, is nonetheless real. And so what the governor has tried his best to do is to accommodate the safety and health of the population, and also as best as possible maintain some sense of economic vitality as we go through it. And so the notion of rolling this forward as counties went positive was aimed at doing exactly that, as trying to preserve as much economic capacity as possible in the face of this. And so that's the conjecture behind it. It will soon be the case, clearly, if our curve is of any value at all. It will soon be the case that all 77 of our counties, to be sure, will have converted into this category of those exhibiting infection. But that's the rationale behind the policy.
Yeah, and certainly for those, we know the governor has put out, especially for the vulnerable population, to stay at home in all 77 counties. We've not restricted total movement throughout the state. And certainly there has been question on what is essential versus non-essential businesses. We have, definitions flying about. We've not actually had an exact definition of that. So a lot of people are out there that don't need to be. And I think this is a time when, as the governor has said, and we stress to him, self-responsibility. It's up to our individuals. You may not be told by your government to stay at home, but you're being told by all the health professionals, stay at home. Lawyers, others don't need to be going into work right now. Everybody needs to be staying at home. So with that, we have a question that it seems like we need to test asymptomatic people in order to understand disease transmission. Needs to be done in a systematic fashion. I'm not sure that's really a question, but Dr. Kupiak, do you want to comment on that?
Yes, there is a tremendous amount of interest, both regionally and nationally, on asymptomatic. I do not believe we know the prevalence of that. And that's the importance of having these, measuring that IgG and IgM antibody test. So we know there are probably people walking around that are asymptomatic that has not been tested and potentially could still be an exposure. And I think without the data, one cannot make that assumption. So we don't have the data, it hasn't been tested, but there is strong indication and belief that there are individuals that are asymptomatic. We know that from just the news reports.
Yeah, Larry, I would highlight just yesterday, a paper was published in MMWR by the CDC that had done testing of 7 different clusters of patients in Singapore, and they were actually able to demonstrate clearly in that paper asymptomatic transmission. So as Tom said and others, we don't know the prevalence of that, but we're pretty sure it happens.
Yes, I agree. I think all the healthcare workers understand that. And in, again, a perfect world, we'd test all close to 4 million people in Oklahoma. Unfortunately, we don't have 4 million tests.
Larry, he mentioned literature, and then another point that we get questions that have been asked that has not been brought up here, but physicians have asked. Actually, an article that I've just read, that Sound Science Before Quick Judgment, regarding RAS blockade in the COVID-19. And this is regarding to ACE inhibitors. It's just like the question that Dr. Hendricks and Dr. Bratzler. So there are other medications. Although hypotheses have been published, we have no direct evidence that ACE inhibitors worsen or increase the risk of the COVID-19. In addition, we have no direct evidence that ibuprofen worsens or increases the risk of COVID-19. So patients really should consider the risk and benefits of stopping or starting their medications and have that dialogue with their healthcare professional.
Yeah, and actually there was an article that came out from the American College of Cardiology, and I had one of our leading cardiologists from OU on earlier in the week, who specifically said, do not stop your medicine. You certainly should talk with your healthcare provider, but don't just stop your ACE inhibitors. So we want our people with chronic illness, whether it be chronic lung disease, chronic heart disease, hypertension, diabetes, to take care of themselves. That helps other patients. If they take care of themselves and stay out of the hospital, then that's a room available for a respiratory patient who may have COVID-19. It's PPEs, protective equipment that's important to be preserved. We actually have a very interesting question, and Jerome, this may be for you. Are there any statewide efforts to protect our non-healthcare frontline workers like grocery, restaurant employees, delivery personnel with PPE who could contribute to community spread?
Yeah, that's a great question. Thank you. And then Larry, if I could also just take a point of personal privilege and mention a little bit about mental health when I finish answering that question, if you wouldn't mind.
Sure.
But thank you very much for that question. We have to date obviously crafted policy around trying to mitigate the impact to frontline workers, grocery, restaurant, and others by virtue of limiting customer interaction to carry out and drive through, as an example. I don't know of any specific efforts around, for instance, PPE. It's been my sort of anecdotal observation that that folks are doing that of their own accord. Again, the efficacy of those, certainly nitrile gloves in any case are, can be effective. Masks, I know there's plenty of debate around whether individuals wearing just surgical style masks, whether that's effective or not. I don't know of any specific policy directives around that at the moment, though, but I will put that on the list of things to check, and I appreciate the question. If I could just mention a little bit of an update and then an encouragement to this group, given the important position you play with Oklahomans. Clearly, we're focused on the physical health of the population during this pandemic, but as you know much better than others, we have a real psychological toll that this pandemic will exact on our population. So I wanted to give some view on what's going on now. I actually just came over back over to our command center here from our Department of Mental Health. And what is happening out in each of our 68 county locations is we're trying to leverage telehealth right now through the provision of iPads in each of these county health locations, such that when an individual enters our location for whether or not for COVID screening, we are asking as part of our protocol if they've experienced increased anxiety, if they feel like they need to talk to someone, and then we have someone that's essentially one punch away available to visit with them through telemedicine. I mention that because I really, it is front of mind to us as well about, again, the psychological toll that this is going to have on our population. We have some, I would say, disturbing sort of early indications on some of our Department of Human Services outcomes. You can just imagine that folks cooped up in the house with kids at home under suboptimal conditions could have bad outcomes for us. And so I simply say this to try to heighten in the minds of all these providers on the line to please keep in mind also mental health of our individuals. And to the extent folks are experiencing distress, we have tried to set up in our county health departments now some resources on the front line to be able to accommodate that. Feedback would be much appreciated as we go through this on what folks are seeing with respect to mental and behavioral health. But we anticipate, unfortunately, having that be sort of a population level comorbidity here.
There's been a question on whether an order, physician's order, needs to be present with the patient for them to get tested. The local media reported that people did not need an order. I think that came out as a change yesterday with the executive order that at least at the state labs around the state, if I'm right, they do not need an order, but the county labs yesterday were still requiring it, and that you all were going to talk with them to try to get that changed, that they now fall under the state mandate. Is that correct?
That's correct.
Okay. This is a very interesting question, especially as a gastroenterologist. There's been reports of viral shedding in the stool for as far out as 30 days. Are the viral particles alive and are they infectious? And I'm not sure who wants to tackle that. Go ahead, Marty, are you? No?
No.
Anthony,
Yeah.
in your infectious disease, what do you say about that? Are they infectious particles?
Actually, I have not seen the data on that, but it's possible. Well, let me look into that further, and then I can loop back to you, Dr. Bookman.
As a gastroenterologist, I do know that up to 40% of patients with COVID-19 have some GI symptoms, including anorexia, loss of taste and smell. And so a question that I will present, Jerome, with people needing symptoms to be tested, is loss of taste and smell or gastrointestinal symptoms adequate to get tested at our state labs?
Dr. Bookman, to date, we have stuck with CDC guidance as we stipulate those symptoms necessary for screening. I haven't seen, although I certainly haven't been on today, I haven't seen that the CDC has included loss of taste or smell or GI symptoms. I haven't seen that yet. I can certainly check into that, but we're trying to hew very closely to CDC and their recommendations on that.
Yeah, they are actually a little behind, and they have recognized these as symptoms of COVID-19. And so we might check on it because we may want to update and certainly allow patients with those symptoms, loss of taste and smell, and certainly gastrointestinal, up to 10% of patients are presenting with GI symptoms. One other question, as we're coming quickly to the end of this, I want to try to get to as many of these as we can. Is there any change in Oklahoma law regarding DNR during this outbreak? And the same doctor asks about telemedicine, consult on a hospitalized patient. And yes, I can answer that. You can use telemedicine. Integris Health, certainly in Edmond, has gone to all telemedicine for consultative services. We're trying to decrease exposure. So telemedicine can be used. I don't know that there's any change in the law about DNR. Does anybody know? Okay. We can check on that. We'll try to get back with you. Another question, do you need an NP swab or is a mid-turbinate swab adequate for PCR testing? Dr. Kupiak, do you know?
Typically, an NP swab would be the most effective, in my opinion.
Yeah, there has been reports where they're allowing even cotton swabs in saline. I don't know the false positive, false negative rate of those, but I know it's being allowed. We have a question from one of our pulmonary doctors. Jerome, does Oklahoma have a policy on scarce resources as to ventilators, and what should clinicians do if there's not enough ventilators?
Yeah, thank you for that question. We actually do have a policy on scarce resources and their allocation. It will be coming out, I believe, Monday. As you can imagine, that's been a highly collaborative effort that we've had to put into effect with updates very recently. So that's a live conversation, but I believe by the 1st of next week, we will have that policy available and ready to be pushed out.
Do you want to talk about the governor's position of 2 COVID hospital centers? And the question is, are there any plans for non-hospital sites?
Yes, thanks very much. So you'll recall that probably 10 days or so ago, the governor gave the general policy directive that we would try to establish COVID centers in Tulsa County and the Oklahoma City metro area. I would say about those were general guidance aimed at launching sort of what our surge effort would look like. Since that time, a couple of things have happened. One, our hospitals have done a truly exceptional job of submitting to the state their respective plans for a 40% surge in their own capacity. So those are being reviewed, collated, and stacked into a plan for 40% surge right now. If you imagine concentric circles, with that being the center, around the far outside has been work undertaken with FEMA and the National Guard about the potential of setting up what might be thought of as either large, sort of Javits Center style, convention center locations, or large mobile MASH type units. That's the furthest out. In between those two is our ongoing work of determining what the surge capacity would look like if we utilized, for instance, the reopening of closed or moribund hospital facilities. That work, again, is live. We've committed to provide to the governor by April 6th our overall plan on what that looks like. Again, the hospitals and the Hospital Association in particular are literally working hour by hour with us on the development of it. And so I think what you will see is a hybrid plan that will likely use something that looks like, a larger COVID center, potentially in the Tulsa area. The Oklahoma City Metro may look something more like a couple of physical locations. And then we're manifestly going to try to leverage the system of regional hospitals that we have to make sure that we're also accommodating the rural areas. One of the limiting factors as we are planning here is emergency transport and more particularly ventilation capacity across our emergency transport. So as we're pulling these plans together, we're certainly accommodating the reality that you as providers would know to be on the ground. But we're noting, most particularly, it's not as simple as just standing up 2 big locations and then expecting everyone can get there safely. So more to come on that, and I believe that the early part of next week will feature us revealing, plans with maps and associated. But I think that's what you can look forward to seeing.
This is a question that I've not heard, and I'll throw it open to any of the people on the panel. Has there been any consideration for ozone treatment or exosome treatment?
I've not heard of any studies related to that topic at all.
Dr. Kupiak, do you have any information on that?
I do not. It's an intriguing question, but I don't have any comments on that.
Okay, I have no answers for that one. One question is where can our frontline healthcare workers go to be fitted for N95 masks? Are the hospitals doing it on an individual basis? Dr. Bratzler?
Yeah, I mean, so we certainly do it both in our practice and also in our hospital system. I don't know that the question has ever come up about people from outside of our system coming to get fit tested, but that's something I'm willing to look into. But we do it for all of our employees that are frontline or patient contact.
There's a comment here that I think Secretary Lawfridge has already at least mentioned, and that is using ventilators that were in our outpatient surgery centers. All elective surgeries have been closed. We have a lot of anesthesia equipment that can be used as ventilators that may have PEEP capabilities, and those are being tapped. So for the person who commented on that, that is being done. I think the last question I'm going to throw to the panel is what research is being done in Oklahoma to help fight the coronavirus? And if so, when will it be made available? There's a lot of different research, both at OMRF and other places. Does anybody want to comment on what's going on in the state of Oklahoma?
So Larry, I'll kick it off and just tell you what I know. Certainly within our own system, and also working collaboratively with some of the biotech companies on campus and OMRF. As you know, there's quite a bit of activity right now on vaccine development that's ongoing here in Oklahoma. We're involved in a number of those trials right now that are just getting off the ground. The other thing, we've put into place protocols for patients actively in the hospital for a variety of different forms of treatment. Certainly, we've talked about hydroxychloroquine and azithromycin, but we're also looking at antivirals like remdesivir and some of the monoclonal antibody drugs to potentially treat, and we have done that on occasion. So I think, and then we have great interest in potentially using convalescent serum to see if it's helpful in our patients, because we're seeing a number of very, very sick patients in our intensive care units.
Marty, do you have anything to add from the pharmacy standpoint?
I don't, but I do have a question, and maybe we have an answer and maybe we don't. When patients get to the point of being on a respirator, are we seeing, what kind of success rate are we seeing once we get to that point? Are we seeing a big decline in the success rate of that patient coming off and then, returning to some form of normal day-to-day activity? And I know this is early, obviously. I mean, but I'm not seeing a lot of evidence out there, or at least the evidence I'm seeing is not very positive, I guess is the word I want to use. But I just, from a doctor standpoint, I'm just curious, what are we seeing in Oklahoma so far?
Dr. Bratzler, do you want to comment on that?
Yeah, I'll try. I mean, we haven't had a whole lot of patients in the ICU on ventilators yet. The national data, though, aren't terribly compelling, that once a person gets to the point that they've developed severe adult respiratory distress syndrome and they have, that diffuse lung injury, the mortality rate is quite high. For those patients that do get better, there's data that obviously some patients do come off the ventilator and survive, but their periods of convalescence are quite long, often weeks before they're fully able to get back outside.
And we do know that when these patients go on a ventilator, they're on it longer. I think the average is 10 to 14 days. There is some evidence that has been reported that those who have survived have come off ventilators after several months may actually have normal pulmonary function. So they may do well. At this point, I want to thank all of our panelists. We've had some very interesting questions. You've given great answers. I hope that all of the people who have participated in this conference have gotten information that's useful, valuable, and will help them in taking care of their patients and themselves. Again, I can't stress enough, tell your patients to stay home. to wash their hands. Hot soapy water. I learned some time ago that the soap is what destroys the fat layer surrounding the virus, which helps to destroy the virus. So it's not just a matter of a quick rinse. 20 seconds with hot soapy water or using a greater than 60% alcohol solution is important. Do it frequently and clean your surfaces. I hope that all of you have gotten valuable information, and I hope you'll be available and again join us for the COVID-19 pandemic series. The next update to be in the very near future, and certainly go on the website at okmed.org if you want to see the live stream or replay of this conference. With that, I'm going to say thank you to all of our participants, and we will close this conference for today. Thank you.